in scar work and then in pelvic and abdominal scarring. And I also teach fascial unwinding and energy awareness. So basically they're all light touch therapies. I'm really a light touch person, and this work is a very light touch. Okay, so I trained originally as a state registered nurse in a former life in the British Army, the Quaranks. Then I moved into complementary health in '92, and I trained in multiple modalities. And then I found the world of fascia and went to the FRC in 2012 and met Sharon Wheeler because I was looking for somebody to help me with my own scars. And I then flew over to train with Sharon Wheeler. I nagged her till she let me train because she used to just train Rolfers and structural integrators. So I flew over and then I came back and I was the only person in the UK who did it. I was a bit on my lonesome, but then we got her over and we started training people. And now we've probably got about 600 people or so trained in the UK. Inspired by the Fascia Research Congress, I founded the British Fascia Symposium in 2012. Oh, actually, that's wrong. It was in, 2014. And that runs every 2 years. And then we were supposed to have the BFS in May 2020, but of course we couldn't run it. And so we went online, we streamed for 5 days, 9 hours a day, and everybody loved it so much. And it just led me to realize there was a huge gap in people's lives, that there were therapists around the world interested in fascia and just isolated. You know, we had people from around the world and they were just isolated. So I set up the Fascia Hub, which is a community education forum. And then also in lockdown, I published Scars, Adhesions and the Biotentegral Body, co-authoring it with Sharon Wheeler. And we had some extra special chapter authors as well. I haven't got time to go through that right now, but I'll show you the book at the end. So that's my brief history. And the work I do, Sharon Wheeler's scar work, light touch, transformative approach to scarring. People get very excited when they realize that they don't have to do much for the whole tissue to change. As we know, intention is half of it, and knowing what you're doing is the rest. Sharon trained with Ida Rolf originally, and Ida Rolf didn't really have a protocol for scars, so Sharon sort of just worked it out, as she would say. She lives in Seattle. She's a very laid back, lovely woman, very modest about her achievements. Sorry, I think somebody's got their microphone on. Could we just mute everybody? Would that be okay, Petra? Thank you. Some little homey noises, snuffly noises going on there. Now, there's very little research into Sharon Wheeler's scar work at the moment, but it is being done. But the empirical results, you know, are impressive, and we have teachers around the world now, and it's spreading and spreading and spreading. And in fact, in the UK, there are some training hospitals that are setting up clinical trials because they're so impressed by the results, even without the research. So let's start looking at scars. What we're going to do is we're going to have a sort of general look at scars. We're going to have a general look at how they affect the fascia, what the fascia is, just a brief revision. I'm sure you all know, but just a brief revision, and how the fascia is affected. Then we're going to have a look at the Brazilian butt lift and the abdominoplasty, the tummy tuck and the Dieppe flap, particular issues there. And then I'll show you a few results from Sharon Wheeler's scar work. And if I see that questions coming up, if I can answer them within the context of what I'm talking about, I will, but otherwise I'll leave them to the end and we can answer them then. Okay, so what's the problem? My scar looks and feels fine. This is the normal thing. People say, oh, I haven't got a scar. Well, I have. I've got a laparoscopy and it's in my navel. You can't see it, so there's no problem. Oh, I've got an appendectomy, but it looks great. But even the smallest scars can have an effect on the body. And even the best healed scars, it can be misleading because it's what lies beneath that's important. And people think it's all fine. But when you start pointing out, getting them to feel a scar, getting them to feel the dip and the drop and the lack of tissue, and maybe the difference in tension throughout the scar, because I always get somebody to feel a scar before I start working on it, because I can be pretty confident that within 10 minutes that scar is going to start changing and they will feel the difference. 10, 20 minutes max. So I'm just going to move this up because that's blocking my view. Right, that's it. Okay, so there's this scar problem here. So I've had to put an arrow there. Oh, we've still got somebody feedback. Have we, Petra? Is it Becca? Sorry, Becca, can you mute? Thanks, love. So this scar, I've had to put an arrow because you can't really see it, but it goes there. And this lady fell when she was a child in a swimming pool. And that was like 40 years before. And then they'd left her at the hospital for a while on a trolley before they sewed it up. And so she was so young that she didn't realize that you should be able to turn your neck more. You know, that was her paradigm. That's what she'd grown up with. And so she didn't realize there was a problem. But after we worked on her in the class, because we bring in scar models, members of the public who would like to have treatment with our supervised students. And she said, after the treatment from the students, I didn't get involved. They were practicing on her. Okay. So freer movement of the area below the lower lip, less attached. Neck rotation much easier with less crunching. Scar feels smoother and twice and wire-like line is almost negligible. So she had a tense little line under there. And distance between neck and shoulders feels extended and relaxed. And when we talked to her, she said, well, no, I didn't really realize there was anything wrong until there wasn't. So we often don't even realize. It just becomes the way we grow up. It's our natural paradigm. We don't think anything's wrong. So look at this appendectomy scar. Is anything wrong with that? Well, it looks good. It looks good, but you've got to think of the position of the scar in the healing process. When the little fibroblasts get to work and start healing the scar, they can be a little over enthusiastic. It's a bit like trying to I always think of the pirate ships, you know, and they're at sea and they've cannons going and holes going in the wooden sides of the pirate ships. The pirates didn't sit around saying, I say, old chap, there's a hole in the pirate ship, in our side. You know, what shall we do? Oh, let's get something nice and fill it and paint it. No. You shove something in the hole to stop it. And it isn't pretty. You know, you shove straw and tar and they block the hole, but it isn't pretty. And it's the same really when you cut in, whether it's surgery or self-inflicted, you know, when you chainsaw or something like that and you hurt yourself, the healing process is designed to stop the hole basically in the skin. So it's not pretty. And if you look at Dr. Jean-Claude Gambetto's film on scars and stiffness, he says it's a bit of a shipwreck under there, and he takes what's it called, Petra? Fiber optics. He goes underneath the skin and he looks at a scar, and you can see it really is, it's an emergency procedure by the body. So all sorts of things get stuck then because adhesions developed, and adhesions stick structures together that shouldn't be stuck together. Okay, so underneath this may be tethered into the ASIS. It may be also feeding into another scar. So if there's a C scar, cesarean scar here, those two are almost undoubtedly going to be feeding into each other under the skin, because degraded tissue will feed into degraded tissue. Whether that tissue is degraded by a scar or by repetitive strain injury or by major impact injury, the tissue, where the tissue is damaged, it feeds into other damaged tissue, and that can be all the way, say, from appendectomy down to a twisted ankle. Yeah, they'll feed in, and you can feel, if you feel on clients, you can actually feel the tension and the connection. Or it could be a laminectomy and a laparoscopy feeding in from the back to the front. So it's never really, not very often is it just a scar. So this affects mobility and functionality, and of course can create discomfort and pain. And do people put it down to the scar? Not usually, not normally. So when I get people in the clinic and I say to them, how do you feel? How does your body feel? And these are some of the things I get told, like not being whole inside. Like my body isn't as strong anymore. Like my top and bottom half don't connect. This is particularly with things like a cesarean section. or a tummy tuck or diep flap, which we'll go into later. A constant ache or nothing, no sensation or feeling. So let's look at what might be happening. What is underneath this scar? So fascia, we're going to talk about. Of course, a lot of things are underneath the scar, but lots of different scars and lots of different structures. I'm not going to go into each one, but let's look at what is definitely behind, but underneath every scar, and that is the fascia. Now, the fascia is a type of connective tissue, primarily made of protein, of collagen, and ground substance and elastin. And it has a very high water content. And it's strong. Sometimes it's like cobwebs, sometimes it's like cling film, depending on what structure it is covering, because fascia will adapt according to the requirements of the body. So it will respond to internal and external forces. So in one place, it might be a sheet of fascia. In other places, it just looks like cobwebs. Different wherever you are, and different according to the needs and requirements of it in that particular part of the body. It's sheathing and continuous with muscles, nerves, organs, bones. Every structure in the body is covered by fascia, right down to cellular level. And when fascia is damaged, the effect can go body-wide because the matrix or net of fascia, which is continuous throughout the body, gets distorted. And we're going to go into this a bit more as we go along. And fascia can exert a tensile strength of up to 2,000 pounds per square inch. That's the resistance of it to breaking under tension. It's therefore capable of pulling joints and vertebrae out of alignment. So if you've got somebody with continual problems with lower back, the best thing you can do for a start is look at the scar and at least sort the scar out. And we'll look into why as we go along. So this is a picture of fascia. It's actually porcine fascia, pig fascia, photographed by Thomas Steffen, but it doesn't matter whether it's pig or human. That's just a sample of what fascia can look like close up. Of course, we're all used to seeing fascia on our meat if we eat meat. Vegetables don't have fascia as far as I know. The meat definitely does. And you can see here the fascia that's sheathing. This is the muscle of the meat, and the fascia is sheathing it. And so because it connects every structure right down to cellular level, and because it is in the form of some kind of matrix and a net, it is not in layers. Layers are artificially created when you cut into it and when you dissect it, and you can see it all looks like strata, but that's not its natural format. If you watch the Jean-Claude Gambeteau films, you can see, and he will say in his very Gallic French way, there are no layers in the body. There are no layers except those that we artificially create. So because there's full fascial continuity in the body, if you restrict in one place, that will have a cascade effect through the tissues. So if you have a scar or a twisted ankle or an impact injury or repetitive strain injury, those will all, or emotional holding, for example, those will all create fascial restriction, and that will affect the body locally to globally, according to so many factors we don't have time to go into today. That's a whole new webinar. So possible or probable effects of this fascial distortion, if looking at the scars that are caused by adhesions, it can create a sort of straitjacket effect. So it's really tight, tightening around your organs, tightening around the joints and other structures. So this is going to affect mobility, elasticity, expansion, and it starts as incremental damage, like it's a little bit, and you think, oh, that's a bit stiff, and then it gets worse, and then it gets worse, and you might go and see somebody and nothing happens unless they're doing fascial work or scar therapy work. And we get used to this new way, and we just think, oh, I'm getting old, well, you're not necessarily getting old, but it's very aging, having these fascial restrictions that are affecting us and these scars. So we end up with this imbalance and compensation patterns and pain and instability, structural instability, can't stand on one leg anymore, can't get up out of the chair anymore, all sorts of things. And do we put it back? Do we link it back to the scars? Probably not. When you talk to somebody about their scar, the scars can be very emotive. Now, when I was a kid, I have scars on my leg. I had hip dysplasia when I was born. I have scars, and my dad was the prime example of intelligent parenting. And he just said, he was told to keep me mobile. So he'd just say, oh, Jan, he said, you run up that tree, get up that tree and I'll take a photo. Or you do that and I'll take a photo. I love to do anything for a photo. So I did all this. So he had me running around. And then he said to me, you know, if you didn't have that scar, you'd be like that lady there with the built up shoe. You wouldn't be able to run. So when people bullied me at school or tried to, I'd say, I don't understand what the problem is, because this scar's great. You know, it means I can run. I wouldn't be able to run without it. And so I never got bullied at school. So but however, most people don't have that positive input, and they look at their scars, children as well, if their parents don't realize that they need to help them, and it makes them feel less attractive. It can make them feel sad. They don't want to touch it. And of course, just think, if you've got a cesarean scar and you don't like touching it, you're not going to want your partner to touch it. So this can have a huge effect on somebody's relationship. There's always that as well. So people feel angry, you know, like they shouldn't have this scar, especially on the face, something really disfiguring. They feel embarrassed, often with the cesarean or the mastectomies, not the cesarean, the mastectomies and the removal of the uterus, hysterectomy. I'm not a woman anymore. That's quite common. And nobody will want to touch it ever. It's repulsive. So these are normal approaches to a scar. And again, we can help the children by not letting them be bullied, by telling them that turning their scar into a badge of honor. And we can help adults as well, just by being willing to touch the scar and helping it to change, helping the tissue to change, helping it to feel more integrated into the body, which is what we would want to do post-operatively. Now then, you're looking at cosmetic surgery, which is what I'm going to focus on today. It's a bit of a different story. I'm not disrespecting all cosmetic surgery. Sometimes people really suffer because they cannot cope with the size of their nose, or that their ears stick out, or whatever. And some cosmetic surgery makes a massive difference to people's confidence. In fact, a lot of it does. Because they do not feel happy with themselves. So I looked at this and I just put, looking at the reasons why people get cosmetic surgery, we have to think about their state of mind. So I put down a few here, issues to consider: insecurity, dislike of themselves, which then translates to a dislike of their body, deep unhappiness with how they look, their body, their face. And of course, remember that nowadays we were just talking about the effect of social media and how it's distorting the body shape, and people are airbrushing and distorting perfectly normal shapes. And so people think that they have to be this incredible shape, which is not really achievable unless you're Kim Kardashian, and that's the problem. So people can feel really angry that they don't live up to society's perceived expectations. Their peers, their friends, their colleagues tell them that these surgeries are worth the pain and the cost. And so do, as we'll see in a minute, so do the celebrities. And that's a major problem as well. If you don't have a sense of self and a really strong sense of who you are, and security and love for yourself, it's very easy to start looking elsewhere, outside of yourself, for help. And if they had a lack of understanding, if they have a lack of understanding of what scars and adhesions do to the body. But if they did understand, would they go ahead? Well, I'm thinking, yes, they probably would. Even if they knew everything I'm talking about today about scars and adhesions and what it does to you, what they do to you, they probably go ahead anyway, because it's about like compulsive eating, you know, or compulsive fasting and starving yourself. It's a compulsion, it's an addiction, and it's a distortion of reality. Self-hatred and the desire to be slim and attractive will often overpower any fear of repercussions. And they allow themselves to believe what they're told, that an abdominoplasty, a tummy tuck, is just a little nip and tuck. No, it isn't. It's major surgery. A revision of a C scar. The cesarean scars maybe not looking too good a few years down the line. They can be talked into full cosmetic remodeling of the abdomen. It's not a nip and tuck. It's potentially hugely damaging, as we're going to see. So what happens when they get their scars? Is their response going to be the same as our normal responses we looked at earlier, about feeling sad or not wanting to touch the scar or whatever? Maybe, but on top of that is this overlay of this compulsion to look good and this desire to be this different person. The scars aren't important. I love my body now. I would still have this surgery no matter how bad the scars were. Nobody can see the scars under my clothes anyway. My partner just wants me to look good when we're out, so it doesn't matter. I don't care if the scars affect my movement. I look fabulous. And it's unlikely that even if the mobility and function worsen due to adhesions, most people don't relate the two. They won't relate the scars to the problems they're experiencing. They won't relate abdominal scarring to bowel problems or bladder problems or reproductive problems. Sometimes they move into a state of regret. Their symptoms can become severe and they lose the initial result. You know, I have people who come to me and they've had breast implants reversed because they weren't sitting properly, they didn't look good, they didn't feel good, had them reversed, and then of course you basically brutalized the breasts twice. And it really does depend on the skill of the surgeon, but even with a good surgeon, things can go wrong. And then part of my job is not just to try and put the breast together, something that looks basically looks like a three-dimensional jigsaw puzzle that has been put together like that, instead of that, but also to start helping them to perceive their breasts differently, to generate a gratitude towards their breasts, a gratitude towards their body for dealing with such surgery, traumatic surgery twice. So when you're working post-operatively, as I'm sure you know, then you are really also always looking at the mind as well, especially around these scars, these cosmetic scars. I think we're going to have a massive problem down the line with some of the scars when people start to realize that the problems they're having are not maybe purely down to the scars, but hugely contributed to by the results of their surgery. So I was having a little look at what the media had to say, and I just picked out a couple of things. Desire for cosmetic enhancement is fueled and warned against equally by the media and image-conscious celebrities. So I've never heard of her, I'm afraid, but Chrissy Teigen, I don't know how to say that name. Chrissy, yeah, very beautiful woman, young woman. And there was this confession thing in, I think it was Harper's magazine, of some of the celebrities and what they'd had done. And this struck me as one which was quite amazing. I'd never even heard of this. She said, I had an armpit sucked out. So basically they cut into the axilla and removed all the fat that had built up. I felt more confident. It made me feel better in dresses. It was the dumbest, stupidest thing I've ever done. The dumbest, but I like it. Whatever, I have no regrets, honestly. And then she went on to say, but actually it's gone back now, so I have to have more of the liposuction. So, but she's still got no regrets. Absolutely no regrets. So people, normal people reading this are saying, well, it's good, if it's good enough for Chrissy, it's good enough for me. You know, she's got no regrets. Yeah, I want to look like her. And then there was in Harper's Bazaar comment, but there are serious concerns about whether this surgery, the Brazilian butt lift, should continue after reports surfaced that the death rate following a B.B.L may be a terrifying 1 in 3,000. Just how dangerous is a Brazilian butt lift? Well, it's extremely dangerous. It's one of the, it is the most dangerous cosmetic procedure, as I understand it from all my reading, looking it up and thinking, how bad is this? And it is bad. It is really bad. And the death rate is exacerbated by a lot of surgeons who possibly don't know what they're doing. And one of the big problems seems to be fat embolism. Well, is fat embolism, in that the fat that's removed from the body and purified can then be injected back into the muscle, because you get a better result. However, you're more likely to get a fat embolism and die if that happens. So it really is rather important when you're doing this kind of surgery, if you're going to go ahead with it, that you at least choose a surgeon who knows things like this. So I'm starting to look, I'm going to look at the B.B.L first, and then go on to the tummy tuck and Dieppe flap. Here are some acknowledged side effects of liposuction that you can find on just clinic web pages. These are the ones that they put out there. This is quite normal. Bruising, changes in sensation, seroma, fluid buildup, infection, scarring, persistent swelling, asymmetry, and discomfort. So the liposuction is going to be people, you will have, if you've not experienced it, you will have seen people having tummy tucks. I recommend that you watch the YouTube videos, not over breakfast, because it is really quite disgusting. And you will see people liposuctioning, and they are contouring the abdomen or the thighs or the buttocks or whatever, according to how mostly they're generally perceived to be most attractive. And then after that, you have any or all of these side effects are quite common. From a fascia point of view, it's brutal, because they're destroying fascia, which is an amazing organ and quite vital. It's not stuff that should end up on the cutting room floor. It's not just packing. Fascia has many different roles and uses, and the last thing you should be doing is liposuctioning it. So I had these pictures from Petra. Thank you, Petra. This is just this is a picture of fibrosis on an abdomen after VASA liposuction. VASA is a finer liposuction tool, and it works with sound vibration and dissolves the fat cells without so much damage. And it's fine for contouring, but it's not necessarily so good for bulk fat removal, which is what the Brazilian butt lift involves. The Brazilian butt lift is basically taking extra fat from areas where it exists, such as thighs, abdomen, for example, and then extracting it by liposuction, often with VASA. And Petra and I have discussed this, and you know, it's really not the appropriate tool for this kind of bulk, or this major debulking of the body, because it can cause, it has to stay in there too long, and it can cause fibrosis, the heated tissues. But in a Brazilian butt lift, they are extracting this fat and they are putting it in vats and purifying it, which basically means moving the blood and the fluid, harvesting the fat cells, and then re-injecting them back into the buttocks to create the sort of Kim Kardashian perky buttocks. Okay, so that's basically the procedure. And here, do you know, Petra, was this actually a Brazilian butt lift client?
Yes, it was. She went to Turkey and she had 9 liters of fat removed from her stomach, her back, her stomach and her back. I don't think she had her thighs. And then grafted into her butt.
Yeah, the problem is if you're going to take 9 liters out, you know, you're going to get very saggy skin. And they use this stuff called Renuvian to skin tighten, but I've also seen research saying that this is not recommended, and you don't agree with it either, do you, Petra?
No.
The use of Renuvian. No, not in this kind of context. So
not,
this is
not immediately after the vaser.
No. So here we have quite a major collapse, which is distressing for the poor woman. And it looks to me like she's actually got a hip-to-hip scar there as well. So she must have probably had a tummy tuck previously.
She did, yeah.
Yeah, so she's got tummy tuck, major liposuction scars on the front. This is all distorted, isn't it? The navel, it's all pulled here. The navel's sucked in. It looks like to me like that's tethered underneath. And then she's got all this problem around the ribs here as well. She's probably having breathing problems, I would imagine, with that. Very damaging. So this is just one of these beautiful pictures. And this is the same thing. Again, this is a different abdomen. You can see the navel. Always look at the navel, because you can see the navel isn't sitting straight. It's pulling over to that side. Can you see it's just being slightly pulled? And there's distortion. Oh, sorry. There's distortion in the abdomen, and another scar here. So what's happening underneath the tissues will be that all these liposuction scars will be feeding into each other. So down the line, you're going to have this almost rabbit warren under the skin of fibrosed tissue. And this is what it looks like from the outside. And this is fibrosis on the back after vaser and Renuvian. Yeah. What can you say? They pay thousands and thousands and thousands of pounds for this. And they look, in their view, fantastic. And then this happens down the line. I don't know how many of them, but I would be surprised if many of them continued with that beautiful shape that they wanted without having to have continuous, constant redos of the cosmetic surgery, just like you have to with a facelift. It's never a one-off thing. So all of those side effects, and then what I see and feel as a scar specialist is this. I can sense and feel and treat and work with the tracking adhesions that follow the pathways forced by the liposuction procedure. So whether you're sticking a drain into a body, or you put a drain into the body during the surgery, but when you pull it out, it creates a tracking adhesion from where it's stuck. Where you're doing a laparoscopy, or you're forcing a liposuction tool in, you are going to end up with tracking adhesions under the skin. And those will often connect into each other. So connection through the tissues between the scars. And that's not necessarily those nearest each other. It can be distal sites, can still connect into each other. You can put your finger on one scar, your finger on the other, tune in, and you can feel the connection between them. And so can the client quite often. The mobility and the fluidity of the tissues is affected. I mean, even before they collapse, like those pictures we've just seen, and discomfort in the surrounding tissues. And since areas of numbness, areas where the tissue feels like plasticine rather than living tissue, so many different things that you can sense that would not be acknowledged, I'd say, generally as side effects. But, you know, as therapists, we tune in very lightly, don't we? And we're used to sensing with very light touch and using these as our biofeedback tool, so we can pick up stuff that, you know, would be laughed at maybe by traditional medicine, I expect. Apart from anything else, the fascia is a vital organ of communication. And some of you will have heard of Robert Schleip. He's a bit of a big name in the world of fascia. And he wrote back in 2012, he started writing about the fascia as a communication organ. So that's just one of its many roles. Mass destruction, a weapon of mass destruction, the liposuction tool. Okay, I just wanted to just, I'm not sure how much you know about the scars, how much you've worked with scars, but I just wanted to give you a little bit of sort of imagining an experiential way of seeing how scars interconnect. So if you think of ironing a tablecloth, putting a tablecloth flat on a table to be ironed, and you can iron and iron and iron it, but if somebody's got a grip in one place, you can't iron that, because from that grip will be radiating folds and pleats from that grip through the tablecloth. So there's the grip and the folds will radiate out. It's never just the grip, is it? There's always the material around it is affected. And then you or somebody else grips the tablecloth in another area, close to it or further away. Let's think close to it to start with. And those folds will spread out. And if those are close, they'll interconnect. And that's a little bit of what's a very simplistic idea of what's going on underneath the skin with proximal scars. Anna, could you mute yourself, please? Thank you. So you've got these pleats and ripples that result and spread out. And that, again, it doesn't have to be a scar. As I said, it can be emotional holding, it can be RSI, it can be traumatic impact injury, anything that creates this sort of fibrotic issue going on in the tissues. And now if you made that a three-dimensional tablecloth, so you've actually, that's the front, the top of the body, and that's the bottom of the body. Say you have laparoscopies on the top, and then you've got laminectomies or mole removals at the bottom. Then you've got the pleats and folds and ripples going through the body. And depending on what's going on in the body, maybe if you always carry your handbag on one shoulder, that will create a twist and a torsion, and that will also affect how the scar patterning develops. So you can end up with this sort of torque and torsion inside your abdomen or your torso, or any limb, of course, anywhere in the body you can end up with that. So can you restore the natural form to the tablecloth while it's being held in this way? No, of course you can't. Of course you can't. You can't iron it flat because it's being gripped. So what we try and do with work where we're working with scars, what we are doing is essentially releasing that grip, releasing the grip. You can't get rid of a scar, but what you can do is to let the tension go, and allow it to integrate into the fascial matrix. So it's a softening and a decompressing and a release of the tension in the scars until they lie flatter. It's never going to be normal tissue, never going to be that tablecloth. Even with, if you iron it, you might never get those wrinkles out. And the same with the body, there will always be an issue because you can't get rid of the scar, but you can reintegrate it. You can restore a lot of mobility, near to normal sometimes. You can help restore function. There's a lot that you can do. But it's not what we see on top that's the problem. It's always underneath. Oh, the Brazilian butt lift. Love the picture, this. And so this lady has had, I think it's primarily women who have this, has had the fat removed from the areas with excess, and now it's being purified. The fat cells have been harvested and it's being injected back to perk up the buttocks. So when they do the Brazilian butt lift, this is the post-operative advice that they give, and I thought it'd be really interesting to just look at this because it gives you an idea of the horror of what these people are going through for the sake of this beauty. Lots of fluids post-operative, do not get dehydrated. Fair enough. Do not sit on your buttocks for at least 2 weeks to allow encouragement of circulation. Sleep without pressure on your buttocks. So you have to sleep on your tummy. Swelling in the genital area, scrotum, vulva swelling, and into legs can last up to 3 months. Lipo results will look worse before they get better. Anxiety and depression may be there for a couple of weeks. This is normal. Put down protective towels before you lie down, as your tissues may leak. The buttocks are initially inflated to cartoon level, sometimes post-op. I put that in, by the way. That wasn't on the official bit. But the official bit is that says 20 to 50% of the grafted fat may be lost. Up to 3 months may pass before the final result is stable. So literally they are inflated to almost like a cartoon, like Betty Boop. That's showing my age, isn't it? Betty Boop. I mean, she's well before my time, but I remember it's the only one I can think of. Oh, well, no, Barbie didn't have buttocks like that. I can only think of the Kardashians otherwise. But anyway, so it's almost like cartoon level, these buttocks. And then they will shrink by 20 to 50% before they're stable again. And meanwhile, they may leak fluid. So instead of using your own fat, polymethyl methacrylate can be used. And warnings have been given about using this by the Brazilian Plastic Surgery Society. This is me putting this in, just as an addendum. There are a lot of warnings by plastic surgery societies about B.B.L. I've read a lot of them, and it's generally considered to be a highly dangerous procedure. And now I've put, if you survive, this came from the Brazilian Plastic Surgery Society, if you survive, months after surgery, there have been reports of fat leaking from the wounds, high fever from infection, and chronic pain. And the fat injected into the muscle can lead to fat embolism. You've got to really, really want to change your body shape to have this. And I think when you really, really want it, you don't listen to the problems. And people, as Petra said, go to places like Turkey or places where maybe the skills are not as good and maybe the care isn't as good, but they go because it's cheaper, unfortunately. And this is where the problems start. So tummy tuck is a bit more familiar. We'll probably all know somebody who's had a tummy tuck. We may even have considered having a tummy tuck. It's not just a little nip and tuck. It leaves a hip-to-hip scar. Now, as a scar specialist, my problem with a tummy tuck, apart from the obvious one of fascial destruction, and wouldn't it be nice if we liked ourselves as we were, I can understand why people have tummy tucks, of course. But when you cut into the skin and you sew those same edges together again, they've known each other. So here's the skin edges. They're cut into. You sew up, say after a C-section or hernia, whatever, and those edges have known each other before. And so they'll actually meld quite well, especially if you do a bit of scar work. You can feel the difference working on those edges to when a tummy tuck is done, or Dieppe flap, which we'll talk about in a minute. Those two procedures require cutting hip to hip, removing a complete wedge of skin, huge wedge of skin, and the fascia and the fat underneath it, and then sewing those skin edges together again. However, those edges now, if you think about it, have never met. They are strangers to each other. And so it's harder to persuade them to get to know each other, to meet again. Just as it would be harder, it's easier to get two friends after a separation to meet up again. But if you get people who've never met each other, getting them to know each other is harder, isn't it? And it's just like that. So normally the skin edges would go together and connect quite well. as we saw in the appendectomy picture earlier, nice, smooth. With the tummy tuck and the DIEP flap, what's going to happen is you're now trying to sew those edges together that have never met, and it's going to be more like that, not like that, more like that. Yeah, so you've got, it's actually, you can feel when you're working on it the difference between the two. And to me, you very rarely get the same result. I can work a lot on tummy tucks, I can improve it a lot. Hip to hip scars, I can improve them a lot, but there always feels that sort of strain and tension in it. Why do they have that strain and tension? I'll go into that now. Once the skin and excess fat is cut away, the new top skin edge above the scar is pulled down to meet the lower skin edge. So you've got the two skin edges. This whole wedge in the middle has been cut away. This has all been cut away in the middle. You've got these skin edges. So now we're going to pull the top skin edge down to meet here, to be sewn. But they can't do that because it's attached to the navel. So they cut round the navel, lift it off, lift the skin off the navel stem, pull the whole thing down. So the hole then is under the scar, goes under the scar. I have seen it where they've measured it wrongly, and the lady had the scar with a little half circle of the navel just above it. She was devastated. All she wanted to do was wear a bikini again. She was devastated. So these, you know, it's quite fine measurements. And then once they've done that, they pull the top skin down, and then they cut a new hole around where the in the skin that's now over the navel stem, and the navel stem pops through, and then they sew it round. And I'll show you a couple of pictures in a minute. So yeah, it's not a nip and tuck. It is major surgery. And these large scars, of course, more potential adhesion damage. Not only are the two ends of the scars over the ASIS, but then the whole length of the scar, you think of the structures it could attach into. Maybe the psoas, iliopsoas, maybe the bladder, maybe the womb, maybe the pubic bone, maybe down into the bowel. So that's the tummy tuck. Now the DIEP flap. DIEP, D-I-E-P, or some people say deep flap. It's the deep inferior epigastric perforator artery, DIEP. When people have cancer, breast cancer, and a mastectomy, single or double mastectomy, there is an option, instead of leaving a flat chest with a scar, there is an option to put fat from your own fat in to replace the breast. They used to do it. They used to take the latissimus dorsi round and bring it round to create the breast. It was actually, in my opinion, a terrible procedure. I have a friend who had that done, so I have first-hand understanding of it. And what happens is that you can see the massive scarring on the back of the person, and then the massive scarring around the breast. But the major thing that happens is it leaves them totally imbalanced. So the musculature at the back is totally imbalanced, and she now suffers from long-term back pain, which I haven't been able to correct. And I have a lot of skills, but I haven't been able to correct it because you can't replace it. She's lopsided. That's it. So she has to constantly exercise, fascially mobilize herself. They don't really do that anymore. So what they do is they take the fat from the belly. So here you've got the hip to hip scar. This is quite a neat example. This is probably the best one I've ever seen. And I saw that on my last course. A lady came in with this. And the nice thing is that it's hip to hip, and even it's not straight across, it's following the contours of the belly. Good. And the navel, it looks quite natural. They haven't sewn around it with a little corona of sutures. You'll see what I mean in a minute. So this is actually probably the best yet flap I've ever seen. And they took the belly fat, and I think it was a single mastectomy. So then they recreated one breast. So they recreate the breast and they take this deep inferior epigastric perforator artery up to provide a blood supply for the breast. Now, that can be really good, often is, but it can, sometimes the blood supply doesn't take. And then you can end up with fat necrosis, and the breast, instead of being perky and normal, will collapse in on itself. Not easy to deal with, even with scar work. Distressing for the person. What would I do? I'd probably opt for a flat breast with a scar, flat chest with a scar, and go for a tattoo. I think I would, because some of these things, and you just put a pad in to fill the bra, because some of these are meant to help, and they often do help, and it makes you feel like a woman again, I've been told, and that's wonderful. But of course, when you're a specialist, post-op specialist, you see all the bad sides as well. Very difficult decisions. But I don't think some people I've talked to actually have never understood what could happen, the things that could go wrong. So the surgery doesn't always turn out as well. This is one of the worst ones I've seen. You can see the navel, the new navel here, they do sort of corona stitches around it, which makes it stand out proud. It takes us a long time to calm that down and to literally roll the tissue like you would roll your earlobe, rolling the tissue very gently until it flattens down. This is before we worked on it. I would say it needed a lot of work. You can see that it's uneven. It's probably been, it looks like this scar's been stretched. I'd say it's probably an infection site. And, or the suturing broke open. Yeah. It's unfortunate. So that's the tummy tuck and the jet flap and the Brazilian butt lift. So I'm a Sharon Wheeler scar worker. What can we do? Right, so these are just some examples of some lovely repairs that people have done. This is nothing to do with the cosmetic surgery. These are just nice before and after photos that I've got to show you to give you an idea. If we can do this on the foot, we can certainly do it on the abdomen and the breast. So this woman was treated by one of my first students. For their homework, I said to them, go away and practice those 9 techniques I've taught you on something really simple. So she chose the neighbor who had this foot. And originally, as you can see, she did have tendon surgery, but no self-respecting surgeon would make scars like this. This is distortion, fascial distortion caused by adhesions underneath. And you can see that the whole body has adapted. If you see how the little toe has changed shape and has rolled laterally to balance. The 4th toe is tucked under the 3rd toe, which is tucked under the 2nd toe. This was done before we realized how important it was to take really clear pictures. So she's chopped off the big toe in this picture. So this lady was due to have 3 months later, around Christmas time, she was going to have a revision, a scar revision, which is the normal response to a problem like this. Her whole body, of course, had compensated round this. It wasn't just the foot that was a problem. She was in her 50s at the time. So my student, who is Sarah Strong, worked on her for 2 one-hour sessions and did this. You can see the lady, she likes her feet a lot more. We've got some nail polish now. You can see that the toes have straightened a lot. This is 2 one-hour sessions by somebody who'd had a day's training. And the tendon scars are a lot straighter. Let's just look at a comparison. It's light, gentle work. It's easy on the client. It's easy on the therapist. For me, it's the most rewarding thing I've ever done. The surgery was cancelled, but then my student had to spend quite a long time rebalancing the body with fascial work because all of the compensation pattern needed to be addressed. Now, this lady, she had an emergency appendectomy. So when it's an emergency, you've got peritonitis, you might die. They don't do a nice little appendectomy scar on the right lower abdomen. They do, I think that was a drain scar, that little one there. They just cut you quickly open. So from the navel to the pubis, she was cut open. And you can see here the pleating unfolds because it would have been a straight down suturing. But over the years, there's this contraction has happened, this pleating and folding of the tissue. And this pulling, can you see there's another drain scar there on the left? This pulling, you can see how the navel's distorted. It's always a giveaway, the navel. It's pulling towards this drain scar. So I would say that this area here around the navel is tethered and connected into the drain scar. Remember I said they connect up underneath. Okay. So this is work by the students. I didn't have any hand in this. So you can see the shape of the navel has totally transformed. There's very little pleating, just a little bit there, still linked to that drain scar there, look. And she's not standing as pulled over on the left, and her scar is more linear, not so pleated. Here they are. This is the before and after. So when she came in as a scar model, you know, they come in for free supervised work with the students. She felt tethered and she had discomfort behind the navel and the pubis. Unsurprisingly, I might say, if you look at it, and can you see that she's really quite compressed on the left there, on the before photograph. She's really pulled down. Everything is being pulled into this left lower abdomen and hip. Everything. And here she's straighter. She still needed some work, but she's straighter. The navel shape has transformed and the pleating is massively reduced. So that was a 2-hour session with the students after they'd been learning for a couple of days. So you can see scar work is very light, very effective in most cases. I never say I'm going to cure it, but I can usually say they're going to feel a difference and feel it and see it within 20 minutes of me working, because just the initial opening moves will, the tissue starts changing. You know, you can see it changing. And I find it incredibly rewarding. I'm a hands-on person. This is what I do. Yeah. So just to recap, scar tissue can affect the superficial, deep and visceral fascia. I wouldn't say they are layers. I'd say they are depths of fascia, each with their own role. We don't have layers in the body. Adhesions can have a body-wide effect because of the fascial continuity and the strength of the fascia. The strength of the adhesions means that joint, bones and organs can all be affected by misalignment, imbalance and reduced functionality. But scars and adhesions can be softened and reintegrated into the fascial web. Normal integrity of the fascia to greater or lesser extent can be restored. Improved balance, movement, form and organ function, etc. result. There are very few people I haven't managed to make a difference to. Some people take a long time. Some people stick very easily. I had one client, she kept having a hip replacement and, well, this was the third one. I saw her after the second one and it was so stuck. I couldn't make a difference. That was 5 years ago. I'm better at my job now, I suppose. So maybe I would be able to make a difference now. She went in for a scar revision and came out, and we don't work on them until they've discharged by the surgeon. But I showed her how to work on herself a little bit, just a very, very light introductory move. But it just stuck again. Some people really stick, as I'm sure you know, and some people don't develop as bad adhesions as others. So when you're looking at somebody's history, always pay attention to their scar history. If a client's not responding to your treatment, the scar may need work. It is not possible to effectively and permanently rebalance someone if they have internal torsion or distortion or torque due to adhesions. And I say that having spent 30 years in the business and only been doing scar work for about 10 years now. So I spent 20 years wondering why people kept coming back and back and back. And I understand now. I do body realignment, so I have a way of treating them with positional release, working on the fascia. Now I work on the scar, then I do the body realignment, and it stays. But it never used to, not always. And now now I realize it was the scarring, probably the scarring. Scar healing restores mobility and elasticity to damaged tissue, restores fluid flow through the tissues. And I would say to encourage the clients to have the work done on new scars to prevent damage down the line. You can work on a scar, whether it's just after discharge or 50, 60 years later. It doesn't matter, the scar still responds. But just think of the limitations they'd be avoiding and the mobility and function that they'll have instead of losing it if they have the work earlier rather than later.